Hello, everybody. Welcome and thank you for joining today on this lovely day. At least it's lovely here. Sometimes me and Rebecca have different weather patterns. Sorry, my computer's going on the fritz. Okay, so today we are doing heart blocks, which is probably one of my favorite topics in this series because people are a little intimidated by it, but actually when you break it down, it's not so bad. So that's why I think I like it. So today I think I'm gonna follow what Rebecca did last time and kind of skip some of the content that we've been repeating over the last few webinars. So we are going to not hugely go over the electrical cardiac conduction system and pacemakers of the heart. We will dive into that a little bit more with our content. Normal components of an ECG interpretation and steps for rhythm interpretation, we are going to bypass as well. But again, if you have any questions about that, you are welcome to ask us at any point. But we are going to dive right into our rhythms. So that's our first degree, our second degree type 1, second degree type 2, our third degree, and then we'll get into left and right bundle branch blocks and some paced rhythms. So we're just going to skip over this content because we reviewed it a few times now and dive right into the rhythms. So today I do have Rebecca with me. She does have to escape a little bit before 11, but she is going to mediate the chat for me or pipe in if I am missing something. And Brooklyn and Laura are not with us today. Anything else to add? You guys, again, like past presentations, please feel free to unmute your microphone if you have any questions, or you can just put them in the chat where Rebecca will be monitoring as well. Okay, so we are going to start with our AV blocks. So atrioventricular or AV blocks. This is a topic that can feel intimidating on an ECG, but we're going to simplify it for you today, like I said. So at its core, an AV block is just a delay or a complete interruption in the signal passing through the AV node, which is kind of like the electrical bridge between the atria and the ventricles. It's important because the AV node is what connects the P wave to the QRX complex. In other words, it's the reason why atrial signals result in ventricular beats. So when that bridge is partially or completely blocked, it affects the timing or sometimes the existence of the QRS after the P wave. So we are going to divide our AV blocks into 4 types based on how much interference there is. So there is our first degree AV block, and this is the mildest form of the blocks. Our second degree type 1, it's also called a wiki block. Our second degree type 2, which is a little bit more serious, also referred to as a Mobitz 2. And third degree AV block, which is a complete disconnect between the atria and the ventricles. So each of these affects the PQRS relationship in a unique way, and we'll break them down next so you can recognize them on a monitor, understand what they mean, and know when it's time to act on them. So the diagram here shows the electrical pathway. So you'll see the SA node at the top, and I'm just going to review this for the purpose of this presentation. So you see the SA node at the top, and that's the heart's natural pacemaker. It generates an impulse that spreads across both atria, including through the Bachmann's bundle to the left atrium. From there, the signal travels through the internodal tracts to the AV node, which is circled here on the diagram. Now this AV node is the key player in AV blocks. So this is the gatekeeper. It holds on to signal just long enough to let the atria contract and fill the ventricles. Then it releases the impulse into the bundle of His, down the right and left bundle branches, and out through the Purkinje fibers to cause ventricles to contract. And I figured out how to use the laser pointer, which I'm excited about. Just the little things. So now we understand where AV blocks happen. So we're going to look at the first type, which is our first degree AV block. So what happens here is quite simple. The signal gets through the AV node, but it takes longer than it should. So on the ECG, this shows up as a prolonged PR interval. So this is greater than 0.20 seconds. But every P wave is still followed by a QRS. So it's a delay and not a drop beat. The PR segment here from the start of the P wave to the start of the QRS is just longer than normal. So here's what it actually looks like on a rhythm strip. So you'll notice that this is interpreted as the underlying rhythm, whether it's sinus or otherwise, with a first degree AV block added on. So the hallmark is that every P wave is followed by a QRS. The QRS is narrow and the PR interval is prolonged. So this is over the 0.20 seconds here. You can see the P waves are upright, uniform, and consistently in front of each QRS. Now, most of the other intervals, like the T wave, QT, and rate, are just dependent on whatever the base rhythm is. So the only consistent abnormality here is the prolonged PR interval. So here's a simple way to think about it. So imagine a line of people walking through a doorway, like the electrical signal moving from the atria to the ventricles. In first degree AV block, each person pauses or hesitates at the door, and that's your PR interval delay. They all still get through, and there's nobody that is turned away. They just take a little longer than usual to get through. And we'll use this analogy as we go through our heart blocks. So what causes first degree heart blocks? Sometimes it's completely normal. We often see this in healthy young adults or athletes with high vagal tone, but it can also be related to underlying cardiac issues like ischemia of the AV node, myocarditis, or cardiomyopathy. Structural changes from things like rheumatic heart disease or even recent vascular surgery can also affect the conduction. We also see it with electrolyte imbalances, particularly in hyperkalemia and during inferior MIs, which often involve the AV node. And finally, one of the most common causes are medications, especially beta blockers, calcium channel blockers, and DIG. And if you haven't seen the trend, DIG seems to cause a lot of things with our heart. So what do we actually do when we see a first degree block? So the key question here, and you'll see this trend through all of our presentations, is assess your patient. How's your patient tolerating this rhythm? Are they showing any signs of decreased cardiac output? So that's our chest pain, shortness of breath, decreased level of consciousness. Do they have low blood pressure? So if they are symptomatic, especially if this develops during an acute MI, we want to treat the symptoms. And if they're bradycardic, follow your ACLS bradycardia algorithm. But most patients with first degree blocks are asymptomatic and often just an incidental finding for them. So that said, it can be a warning sign of a conduction system disease. So we should always continue to monitor, especially if the block is new or if the patient's condition changes. So this is our second degree type 1 AV block. We also call it a wiki block. Here, the AV node gets increasingly sluggish. So each time it tries to conduct, it takes a little longer until it eventually fails to send a signal to the ventricles completely. So on an ECG, the PR interval gradually lengthens and then a QRS gets dropped. So after that, the cycle will just reset itself. So there's no set pattern for how much the PR interval increases. It varies, but the key is the progressive lengthening before that drop. So here's what it looks like on a rhythm strip. So you'll notice the arrow pointing to the missing QRS. So that's where the conduction has failed after a progressive PR lengthening. So the atrial rhythm is regular. P waves march through consistently, but the ventricular rhythm is irregular because of those drop beats. So you'll see the PR intervals getting longer and longer, then one P wave not followed by a QRS. After the drop, the cycle will reset itself. So the QRS complexes that do occur are narrow, and some P waves are left hanging with no QRS behind them. The block is easy to miss if you're not looking for that progressive PR change. So if you're seeing irregularity with group beats, check those PR intervals. So back to our analogy. So we're going to picture a line of people approaching a doorway. The first few make it through, but each person takes a little longer than the last to cross. So eventually one of those hesitates too long and doesn't make it through at all. And that's your dropped QRS. Then the next person steps up and the whole process starts again. So that's exactly what's happening with our wiki block. Progressive delay at the AV node until one beat gets completely blocked. Second degree type 1 blocks are often caused by some form of degeneration of the conduction system, like a fibrosis that slows our AV node over time. So you may also see it in patients with ischemia, especially involving the left coronary artery or during an inferior MI. It can also be triggered by acute myocarditis or as a result of a underlying heart disease, in particular severe coronary artery disease. Sometimes it's transient, especially in younger patients or with reversible causes like infection or ischemia, but it's still something we need to monitor closely. So when we see this rhythm, again, our very first question is our patient tolerating it? If they're asymptomatic, we still monitor, but we stay alert because wiki blocks can sometimes progress to a more serious block. But if they're symptomatic or bradycardic, we go to our oxygen, make sure we have IV access, stop or hold any meds that can slow conduction. So that would be our beta blockers and our calcium channel blockers. We want to notify our most responsible physician and be prepared to possibly give IV atropine or consider temporary pacing if our bradycardia worsens. In severe cases, we may need to start dopamine or an epinephrine infusion to support perfusion. So this rhythm can look harmless at the first glance, but a patient's condition can change quickly. So now we're going to move on to our secondary type 2 AV block. So this is also known as a Mobitz 2, and this is one that is a little bit more concerning than the type 1. So unlike type 1, where the conduction gradually slows, here it's kind of an all or nothing. So the AV node either conducts the impulse or it completely fails. The PR interval stays constant in the beats that do conduct, but then suddenly a QRS complex is dropped without warning. There's no progressive lengthening like we see in the wiki block or the type 1. It's just a sudden, unpredictable loss of conduction, and that's what makes this rhythm potentially dangerous. So this is what a type 2 or Mobitz 2 looks like on a strip, and this is where the pattern recognition really matters. So you'll see more P waves and QRS complexes, and the P waves are regular, but the QRS drops suddenly, like the two arrows here on the strip. So the key clue is the PR interval on conducted beats is constant, and then suddenly there's no P wave. There's a P wave with no QRS behind it. So unlike the wiki block, there's no warning, there's no progressive lengthening, just an abrupt block. The rhythm is irregular due to the unpredictable drop beats, and that makes it dangerous, especially if the ventricular rate is low. So here's our doorway analogy again, this time for second degree type 2. So imagine people walking through a doorway, and each one at the same steady pace. That's your constant PR interval. But then every so often, someone just isn't allowed to go through the door. They just get completely blocked. So there's no slowdown, there's no hesitation, there's just a sudden stop in conduction, which is exactly what happens in a Mobitz 2 when the QRS is dropped without warning. So Mobitz 2 is usually a sign of a serious underlying conduction disease, system disease. So we often see it again with some fibrosis in the His-Purkinje system, or if patients with significant coronary artery disease, especially involving the left coronary artery, are or following an inferior MI again. Other causes include acute myocarditis and structural heart disease, like severe CAD. So the key takeaway here is that Mobitz 2 is rarely benign, and it usually reflects damage below the AV node and often requires urgent intervention. So how are we going to treat this? So again, we're going to see if our patient is actually tolerating this rhythm. We're going to look for those signs of low cardiac output. Same thing if they're symptomatic. We're going to start with our oxygen IV access. We want to call our MRP. The key point here between the type 1 and type 2 for second degree is that we want to try to avoid atropine with our type 2. It's often ineffective with our Mobitz 2 and can actually worsen the block because usually it's beyond that AV node. So instead, we want to go towards temporary pacing. Usually that would be transcutaneous first and then hopefully transvenous if needed. And we can consider our dopamine and epinephrine infusions for hemodynamic support. So again, reiterating, this can be a high-risk rhythm, and it can often progress to a complete heart block, and you may also see PVCs, which can further compromise cardiac output. So now we're into the most serious AV block, which is our third degree, also referred to as a complete heart block. So in this rhythm, the AV node isn't conducting anything, it's completely blocked. So no signals are getting through the atria to the ventricles. The atria and ventricles are now functioning on a separate pacemaker system. So the atria might still be under SA node control, but the ventricles are doing their own thing, usually from a slower escape rhythm. So on the ECG, you'll see P waves and QRS complexes, but there's no relationship between them. They're just firing independently with no connection. So here's what a complete heart block looks like. None of them do look the same. You'll notice both the P waves and QRS complexes appear regular, but they're not talking to each other. So there's no consistent relationship between them. The atrial rate is usually normal. It's usually around 60 to 100, but the ventricular rate is often slower depending on the escape pacemaker. So if it's junctional, the QRS is narrow and the rate is usually between 40 and 60. And if it's ventricular, the QRS is wide and the rate drops to 20 to 40. And most importantly, there's no measurable PR interval. The P waves are just marching through without coordinating with the QRS complexes. So this is a classic sign of AV dissociation, which is the hallmark of a third-degree heart block. One quick tip to help you figure out where the escape rhythm is coming from in a complete heart block is to look at the QRS width. So a narrow QRS usually means the backup pacemaker is firing from higher up, so near the AV junction or upper ventricles. So this allows the ventricles to still depolarize through the normal conduction pathways. But if the QRS is wide, it likely means the escape rhythm is coming from lower down in the ventricles and the signal speeds up more slowly cell to cell, which is why you get a wider complex. So back to our analogy. So imagine a line of people. Your people will be your P waves, and they are waiting to go through the doorway, which represents the AV node. So in this case, the door is completely shut. No one is getting through, and that's exactly what's happening in the third degree AV block. The atria and ventricles are completely disconnected, and the ventricles rely on their own backup pacemaker to keep beating. So this is why you'll see P waves and QRS complexes, again, with no relationship to each other. They're just doing their own thing on both sides of the door. Complete heart blocks are almost always a sign of a serious disease conduction system problem. So it can be caused by degeneration or fibrosis of the pathways again, or by an MI. So this can be either inferior or anterior MI that cause damage to the bundle branches lower down. We also see in cases of, we see this in cases of medication toxicity, especially with digoxin, beta blockers, or calcium channel blockers. And all of these can suppress the conduction system through the AV node. But regardless of the cause, this rhythm usually requires some urgent intervention and often pacing. So when you see a third degree heart block, again, true emergency, especially if the patient is symptomatic, and most of them will be. So we start with how is the patient tolerating the rhythm? We look at our low cardiac output assessment again. We look at where the escape rhythm is coming from. So if it's junctional again, that's the rate of 40 to 60. And the prognosis is a little bit better with that one. And if it's ventricular, you will see that wide QRS in the rate lower of 20 to 40. So the risk is much higher with the ventricular escape rhythm. So if the patient is symptomatic, we want to call our MRP right away. There's the oxygen IV access like we typically do, and we want to prepare for temporary pacing. So we usually start with transcutaneous, but be ready for transvenous. So get that crash cart and put those pads on your patient. And then again, you might need dopamine or epinephrine infusions to support perfusion for these patients. The algorithm here is a quick way to sort out AV nodes based on the PR interval. So something that's really helpful when you're looking at a monitor and trying to make sense of what you're seeing, this is a good referral point. So we want to start by asking, is the PR interval consistent, or is it variable or absent? So if it's constant, you're looking at a first degree heart block or a second degree type 2. If the PR interval is changing or there's no clear pattern at all, it's either a second degree type 1, so a leaky block, or a third degree heart block, which has no relationship between the P and the QRS. And to help lock it all in, here's a classic memory aid that a lot of us have memorized, and it's quite handy. I still use it. So if the R is far from the P, and then you have a first degree, longer drop, then you have a wiki block. If some P's don't get through, then you have a Mobitz 2. And if P's and Q's don't agree, then you have a third degree. Okay, now we are going to move on to our bundle branch blocks. And then maybe a little break after this. So bundle branch blocks. So we've covered our AV blocks. We're going to briefly shift to our bundle branch. So these blocks happen lower in the conduction system, specifically within the ventricles, after the impulse has passed through the AV node and bundle of His. So as shown here, the left and right bundle branches are responsible for sending the signal from the bundle of His down to the Purkinje fibers, which trigger ventricular contraction. So a bundle branch block occurs when there's a delay or obstruction in one of these branches, meaning the impulse can't travel normally down both sides. This results in a asynchronous ventricular depolarization, which you'll often see on an ECG as a YQRS complex. So unlike AV blocks, which are all about the atrioventricular conduction delays, bundle branch blocks are about how the ventricles depolarize, and they can significantly affect how the heart pumps, especially if combined with other conduction issues. So we'll quickly break down how we name the different parts of QRS complex based on the direction or of deflection and the sequence of waves. So I find this one a little bit confusing, so it's okay if you don't get it right away because I definitely did not. So if the first deflection is negative, it's called a Q wave. If the first deflection is positive, there's no Q wave. Instead, you go straight into an R wave. So any negative deflection after an R wave is called an S wave. So now if there are multiple upward or downward deflections, we use the terms like R prime or S prime. So for example, the RSR1 or the RSR1, depending on the case, so upper case versus lower case. So this naming system helps us accurately describe what we see on an ECG, and it becomes especially important when diagnosing things like bundle branch blocks or ventricular hypertrophy. So here's how we name positive deflections on the QRS complex. So again, any positive wave in the complex is called the R wave. If there's a second positive deflection, which we sometimes see in conditions like bundle branch blocks, we call it an R prime, written as a uppercase R1. And although it's rare, there's a third positive deflection, and it is called an R bis wave or an R double prime, which is written as an R with the 2 hash beside them. So this consistent naming helps us again describe our complex waveforms. I personally have never used this, but it's definitely good to know. I don't know if you have actually used this, Rebecca. Have you? If you're still with me.
I use it. Sorry, my camera's off. I use it more when we start talking about measuring for like left ventricular hypertrophy and axis deviations, things like that. It's important to kind of understand.
And we get more into it there in those presentations. Good. Then I won't go into a lot of detail because it can be a lot.
Yeah, I just threw it in here because on our bundle branch blocks, you're going to see some different waveforms than you usually see on our usual QRS complexes. So they follow some of those different patterns.
Okay. So bundle branch blocks continued. So patients can have a right bundle branch block, a left bundle branch block, or in rare cases, they can have both. So these blocks can be either complete or partial, depending on how much of the pathway is affected. So now definitive diagnosis of a bundle branch block, it always comes from a 12-lead ECG, and that gives us a full picture, especially with chest leads V1 and V6. But at the bedside, we're usually watching lead 2 on our monitors, which isn't great for spotting bundle branch blocks. So if you do suspect a bundle branch block, you want to look at the V lead on your bedside monitor, especially using V1 or V6, depending on how your system works, because this gives us the best view of ventricular depolarization. So today we're going to focus on how to recognize bundle branch block patterns in the V lead using continuous cardiac monitoring. So even without a full 12 lead, you'll know when something doesn't look right and when to escalate. So when you're using the V lead on a bedside monitor, you're usually looking at lead V1 from the standard 12 lead ECG. So that's what we'll use as our reference point. So here's an example of a normal V lead morphology. V1 can be slightly or very slightly from person to person, but generally you'll see a biphasic P wave, usually mostly upright, QRS complex with a large deep S wave, and a T wave that's inverted, which is normal in this lead. So this is your baseline, what a typical V lead should look like during continuous monitoring. The key is to get familiar with this appearance. So when you see a change in the QRS shape, especially winding or unusual patterns, you'll know it may be a bundle branch block or another ventricular conduction issue. So when we see a left bundle branch block, it means the normal pathway to the left ventricle is blocked. So the heart has to take longer or more indirect route to get the job done. So here's how the pulse travels in the left bundle branch. So first it moves down the right bundle branch. Then it activates the interventricular septum from right to left, which is the opposite of normal. Finally, the impulse reaches the left ventricle last, resulting in a delay. So because of this detour, the QRS becomes wide, so typically greater than 120 milliseconds. And you'll also see a very different QRS shape in the V leads, especially in V1 and V6. So this delayed and reversed activation changes the entire pattern of the ventricular depolarization, and that's what we look for on the monitor. So here's what to watch for when you suspect a left bundle branch block on the bedside monitor. So first, the QRS is wide. That's your most consistent clue. It'll be prolonged in all leads, usually more than 0.12 seconds. If the V lead, in the V lead, and the QRS will often end in a terminal negative deflection. So meaning the last part of the complex dips below the isoelectric line. So you'll see a discordant T wave, and that means the T wave goes in the opposite direction of the QRS. And the J point, so this is where the QRS meets the ST segment, is usually elevated, and that's where things get tricky because left bundle branch blocks already distorts the QRS and ST segment, and it can mimic a STEMI. So how can we tell the difference with this? Is the ST elevation is more than 25% the height of the preceding S wave. It's concerning for infarction. Concordant ST changes, so especially in ST depression in the same direction as the QRS, should always be taken seriously. So one of the biggest challenges with the left bundle branch block is that, again, it can mask or mimic ischemia, so especially in ST elevation. So on this slide, you'll see two side-by-side ECG patterns. So the one on the left shows the normal or expected ST to T changes we often see in left bundle branch block. So discordant T waves and some baseline J point elevation. The one on the right shows changes that are not expected, and these are concerning for ischemia or infarction. So in right bundle branch block, the initial part of the conduction is still normal. The impulse travels from the AV node through the left bundle branch. So it activates the interventricular septum from left to right instead of the right to left in our left bundle branch block. And then it activates the left ventricle. So the problem here is the right bundle branch is blocked. So, excuse me. the right ventricle doesn't receive the impulse through the normal fast conduction system. Instead, the impulse has to cross the septum again and travel slowly through the myocardium to reach the right ventricle. This delay creates a second wave of depolarization, which is what causes the wide QRS complex and often the characteristic RSR pattern in V1, which I will show in a minute. So with right bundle branch block, septal and left ventricular activation are unchanged, but the right ventricular activation is delayed. And that's the key difference between the two. So here's how to spot a right bundle branch block on a bedside monitor, and especially in the V lead, which again corresponds to the V1 on a 12 lead. So the first clue, just like left bundle branch block, you'll see a prolonged QRS in all leads, usually greater than 0.12 seconds. But here's what is classic in a right bundle branch block. The QRS in the V lead ends with a terminal positive deflection, so it finishes above the isoelectric line. And this gives it a distinct rabbit ears appearance, which is the RSR that I was referring to. And that's what you're seeing here. So a good memory tip is right equals rabbit. Those bunny ears, I like to call them bunnies, in V1, that is your right bundle branch block. So you'll often see a discordant T wave, meaning it points in the opposite direction again from the QRS, and sometimes ST depression due to abnormal repolarization. So once you spot that RSR pattern or the bunny ears or the rabbit ears in a wide QRS, you're likely looking at a right bundle branch block. But remember, if you are unsure, you need to consider getting a 12-lead ECG. So the hallmark of any bundle branch block is a prolonged QRS complex, again, greater than 0.12 seconds in all leads. Here's an important distinction. All bundle branch blocks have a wide QRS, but not all wide QRS rhythms are bundle branch blocks. So what else causes wide QRS complexes? We have our ventricular rhythms, like our ventricular tachycardia or idioventricular rhythms. Hyperkalemia can cause it, pre-excitation syndromes, pace rhythms, and then toxicities or medications that slow conduction. So a bundle branch block is part of the rhythm, but it's not the rhythm itself. So you need to interpret it as, for example, a normal sinus rhythm with a left bundle branch block, or an atrial fibrillation with a right bundle branch block. And finally, to confirm whether it is a right or left bundle branch block, please get a 12-lead ECG and don't base it off your bedside monitor alone. And our presentation has disappeared. Rebecca, are you there? There's always technical difficulties at one point in time.
Yeah, working on it. I don't know what happened there.
Mm.
Is it
I
back?
swear I'm repelling technology. Yeah, I just repelled technology this week.
Yeah.
They all hate it. So left bundle branch blocks is, so these are the etiologies of our left and right bundle branch blocks. So left bundle branch block is often associated with some form of serious left heart issues. So this can include an acute anterior MI, coronary artery disease, left ventricular hypertrophy, heart failure. Sometimes it's idiopathic or due to reversible causes like hyperkalemia or digoxin toxicity.
I don't think you took over the slides. I didn't see the slide change.
Maybe I have to redo that. Take
Sorry.
control.
There we go.
No, you're good. See it now?
Yep.
Cool. So then our right bundle branch block etiologies can include CAD, acute pulmonary embolism, pulmonary hypertension, congenital heart disease, And sometimes you can see this after procedures, like during cardiac catheterization. So when you see a bundle branch block, we shouldn't just stop and recognize it. We should think about what might be causing it as well, especially if it's new. So back to our what do we do about this if we see a bundle branch block on a monitor? So number one, see how our patient is tolerating the rhythm. Are they symptomatic? Look for your cardiac output symptoms. So do they have chest pain, shortness of breath? Are they dizzy? Are they hypotensive? Is this block new? And if it is, what has caused it? It can be, again, related to an MI, PE medications. Is there electrolyte imbalance? Is there a reversible cause for this that we can maybe fix? How do we know if it's new? You should compare it to old ECGs if they have one. Look at your patient's chart history, if they've maybe had some previous cardiac history. And then finally, to determine if the block is severe or symptomatic, or if it's part of an advanced conduction disease, we may need to escalate it to maybe pacing, um, or maybe a cardiac resynchronization therapy or CRT, especially if heart failure is correlated with the left bundle branch block. So again, we don't just interpret the rhythm. We have to determine if it's dangerous for this patient. Is it new? And does it need some form of escalation? So actually, I might pause here to take a 5-minute break if everybody is okay with that. Yeah, maybe come back at 10:20. I feel like we're kind of flying through these a little bit. What do
We
you
are
think?
fast today.
Yeah, I usually talk way more. I feel like I'm just flying through it. Um, how do people feel about coming back at like 10:20? What do you think, Rebecca?
I think that's good.
Okay, sounds good. I'll see everybody at 10:20. Go stretch your legs. I hope everybody had a good stretch. We are going to finish off by talking about paced rhythms, and then we'll get into some scenarios. So there are three main types of pace rhythms. We have our atrial paced. This is where the pacemaker stimulates the atria. Our ventricular paced, where only the ventricles are paced. And then we have dual chamber pacers, which pace both the atria and the ventricles. So the first thing you'll see on the ECG is a pacer spike, a short, narrow vertical line that represents the electrical stimulus from the pacemaker. It should appear right before the waveform it's meant to control. So that's either a P wave for atrial pacing or QRS for ventricular pacing. Then we assess for capture, which means the electrical impulse is actually causing the heart to respond. You should see a pacer spike followed by the expected QRS complex and most importantly, a palpable pulse. So we want to think of it as a conduction. So the impulse is delivered, and contraction, the heart responds. So if you see pacer spikes without a QRS or the patient has no pulse, that's a loss of capture and that is an emergency. And we will get into that as well. So when a pacer spike appears on an ECG, it should be immediately followed by either a P wave or a QRS complex, depending on whether the pacemaker is set to pace the atria or the ventricles. The key point is a spike alone doesn't mean capture. It just tells us the pacemaker fired. If there's no P or QRS after the spike, then the heart didn't respond. And that means there's no electrical capture. So we're going to look at the strip shown here. So on the left, you see a paced bradycardia without capture. There are spikes, but they're not followed by any meaningful cardiac activity. On the right, sorry, they're up and down. You'll see a paced rhythm with electrical capture, and each spike is followed by a clear QRS complex. But we still need to go further. So electrical capture means the signals got through. Mechanical capture means it's actually caused contraction. So I guess, again, we assess the patient. Do they have a pulse with HQRS? Is the LOC stable or improved? Is the blood pressure holding or rising? And are they warm, dry, and pink with good cap refill? So this confirms that the pacemaker is not just firing, but is actually making the heart pump effectively. In atrial pacing, the pacemaker is stimulating the atria. So you'll see a pacer spike just before the P wave. The spike represents the pacemaker firing an impulse to trigger atrial depolarization. After the spike, you should see a P wave followed by a QRS complex, assuming the AV node is intact. If there is a spike but no P wave, that could indicate a loss of atrial capture. So always confirm the full sequence: spike, P wave, QRS, pulse. This confirms that both electrical and mechanical capture are intact. And I just like to keep reiterating that. In ventricular pacing, the pacemaker delivers the impulse directly to the ventricles. So you'll see a pacer spike just before each QRS complex. Because the impulse is starting in the ventricular muscle rather than traveling through the normal conduction system, the resulting QRS complexes are wide, usually greater than 0.12 seconds. So this is expected and normal in ventricular pacing. On the monitor, we want to look for a pacer spike followed by a wide QRS, then confirm a palpable pulse. Again, if the spike isn't followed by a QRS and there's no pulse, we may have a loss of capture and need to intervene. With dual chamber pacing, the pacemaker stimulates both the atria and the ventricles. helping maintain a coordinated rhythm that mimics the heart's natural conduction system. So on the monitor, you'll see a pacer spike before the P wave, indicating atrial pacing, and a second spike before the QRS, indicating ventricular pacing. So this is sometimes called AV, I'm losing my voice slowly, sequential pacing, and is commonly used in patients with AV node dysfunction or advanced conduction blocks. So just like the others, we want to assess both pacer spikes, I'm losing my words, a P wave and a wide QRS, and most importantly, a pulse to confirm mechanical capture. So this may look busy on a monitor, but it's actually a very well coordinated system, keeping both chambers in sync. So looking at this strip, we see consistent pacing spikes followed by QRS complexes confirming capture. But then the pacing stops and we see the patient's intrinsic rhythm taking over. So when you look at this, are you guys happy with this rhythm? Are you concerned about this rhythm? What are your thoughts on this rhythm? And again, you can unmute your mics or you can throw it into the chat if you'd like. Are you happy? Are you unhappy?
I'm going to try to answer it.
Yeah.
I think when the patient's rhythm pick up, I think the pacemaker is probably set not to pace when the patient's pacer is own pacer is pick up. So I
Yes,
think this
absolutely.
is good. I think this is okay for the patients.
For sure. So this is exactly what we want a demand pacemaker to do. So it monitors the heart and it only fires when it's needed. So once the patient's own rhythm becomes fast enough and regular enough, the pacemaker backs off essentially, and that's normal. So again, this is why it's important to assess the full clinical picture. Is the rhythm appropriate for this patient? Is there a pulse, which I did see pop up in the chat, which I'm happy you said. And is the patient alert, profuse, and stable? So looking at this rhythm alone, I would not be unhappy with this at all. It looks like the pacemaker is doing its thing, but definitely make sure you check a pulse, check your patient. The full clinical picture is important, but overall, yes, we are happy with this. So good answer. So pacemakers, usually reliable, but sometimes they can malfunction. So here are the four main types of pacemaker failure, and each one of them are shown here. So we're going to start with our failure to capture. So you'll see pacer spikes, but they're not followed by a P wave or QRS. So the pacemaker fires, but the heart doesn't respond. So clinically, there's no electrical or mechanical response, and typically you might find no pulse with this one. So this is a escalate immediately. This is an emergency go blue situation. Then there is undersensing. The pacemaker fails to detect the heart's intrinsic activity, so it fires inappropriately. So possibly during repolarization. On the strip, you'll see the pacer spikes at the wrong times, even when a native beat is present. So this can be dangerous. There's the risk of R-on-T phenomenon or loss of synchrony. So this needs a prompt evaluation for sure. We have our failure to pace. So there are no pacer spikes at all when you expect them, even though the heart isn't beating on its own. So this can lead to significant bradycardia or asystole as well. So this is where we want to try to check our batteries, leads, connections, and escalate appropriately. And then there's oversensing. So the pacemaker here is too sensitive and it misinterprets external or internal signals as heartbeats. So it holds back from firing. So on the strip, kind of long pauses between beats, no pace or spikes when needed. Patients may be symptomatic due to inadequate pacing. And sometimes there can be technology interference with these as well. You guys made it through the content. Yay. Flying through, we have some case studies in rhythms that we will go through. And we'll start with the first one. So this is super tiny. Again, feel free to unmute or type in the chat. I think Rebecca is with us for a little bit longer.
Yeah, I'm here.
Okay. A 75-year-old male presents to the ED with complaints of intermittent dizziness and mild fatigue over the past week. He denies chest pain, palpitations, or syncope. This medical history includes hypertension controlled with medication and hyperlipidemia. Vital signs, so his blood pressure is 135/85, heart rate 62, rest rate 16. He is 97% on room air and afebrile. Labs show electrolyte and TSH are within normal limits, and troponin is negative. You put the patient on the cardiac monitor, and this is what you see. So I will give you guys a minute to interpret this rhythm. Okay. There's some answers for you guys, and then we'll move on to some additional questions and follow up. So this patient is in a second degree type 1 heart block. So good job on the chat that I saw pop up. So first question we want to ask with this is this patient considered stable or unstable? What do you guys think? Stable? Stable. Yes, I would agree. We would still monitor closely because a second degree type 1 can progress. Yes, exactly. It needs ECG and monitoring. What else do you want to know about this patient? What would we want to know? We're going to do an ECG and throw them on the monitor, but what else do we want to know about them? Yes, what meds they're taking for their hypertension. Is this new or old? Great. Good. Those are two big ones. We know that his electrolytes are fine, so that's good. If he has a history of heart issues, yes, we know he has hypertension, but does he have anything else going on? Maybe has he had a recent MI? Then we want to know what our 12 lead is going to show because we're doing that. We want to take our vitals now, see what his hemodynamics are currently with his symptoms, and continue to monitor his symptoms. Are they getting worse? Are they going to improve? Are they stable? What interventions do you anticipate for this heart rhythm? What are you going to do for him? His fluids, in and outs are always important, especially in the ICU environment. We love our ins and outs. So we're looking at his medications. What are some meds we want to make sure he might not be on that we might hold? Yes, slow down conduction. Exactly. So that's our beta blockers, calcium channel blockers, our digoxin. What else? So this rhythm does have a potential of escalating. If it's new, if it's old, it can progress. So what do we want to be prepared? How are we going to be prepared for that? If this patient does deteriorate, what do we want to make sure we have? Pacer pads. If he does deteriorate, for sure, pacer pads. Oxygen if needed. Yep. Yep. Sedation pain if we do end up pacing the patient, but you also want to make sure he has IV access. Perfect. Yes, crash cart ready. We might want to, depending where he is, admit him to a place with higher monitoring that has a monitored bed. So whether that's a ward with telemetry or ICU. Good. And we want to make sure we call our physician, especially if this is new. Prepare. So I did see atropine back in there. Atropine is something you need to be cautious of for type 2. Or type 1 atropine is okay, but be ready for a transcutaneous pacing, like you said, and be prepared if this does escalate for dopamine or an epi infusion as well. So that would be more ICU level care. And make sure you know what his status is as well, because we need to know how far we escalate his care as well. Any questions about that one?
I put it in the chat as well, but the other thing that I think is important to remember is the patient's symptoms could be completely unrelated to this heart block. If this is a new heart block, the symptoms could be definitely from it. But if this is something the patient lives with day to day, these symptoms might be completely unrelated to this heart block, especially considering the patient's heart rate is still in the 60s. We don't have vital signs in this case study. So just important to, just because we find something abnormal doesn't mean we stop our investigations.
Yeah, and he is an older gentleman with complaints of dizziness and fatigue, which could be maybe he hasn't been eating, maybe he hasn't been taking his medications. And maybe this rhythm is completely normal for him and he's lived with it for years. So we'll jump to case study number 2. So a 72-year-old patient arrives at the ED with complaints of dizziness, palpitations, and near syncope. He appears pale and diaphoretic with a weak, thready pulse. Patient states he has a pacemaker inserted 5 years ago. So his vital signs, he has a blood pressure of 110/70, rest rate of 18. He's 96% on room air, and he's afebrile. So this is what you see on the monitor after you hook him up. And give you guys a minute to interpret. And if you can't interpret this right away, are you concerned? Yeah, it's great. Yes, you are concerned. Exactly. Great. So this is failure to capture. So the pacemaker is firing, so you can see the pacer spikes, but the heart isn't responding. So this is a true emergency. The heart is not reliably contracting, and the patient is already showing signs of poor perfusion. So sorry, I have to zoom in on this because it's so tiny on my screen. What do you anticipate would be done in this scenario? Pacer interrogation. We want to check the external factors. So is it one, our monitor set up correctly? Are the leads loose? Is there electrode displacement? And then we want to check our pacer settings and interrogate the device. So exactly. So some things to consider, pacemaker, battery, or lead malfunction. So it could be failing after 5 years, and lead fracture or displacement is possible in this time frame. What else? Inform MRP, pacer pads in meantime. Great. That's great. And then all of our other typical stuff. What do we want to ensure we have on our patient? Yeah, exactly. Monitor clinical, get all of our hemodynamics, IV access. Right now, he doesn't need oxygen. So, point is, just because you see pacemaker spike doesn't mean it's doing its job. If there's no capture, this can be an emergency, especially in a patient with a history of pacing and symptoms of poor perfusion. So remember, capture equals conduction plus contraction. Without both, the patient is not safe. Anything else to add? We will jump on to case study 3. So we have a 68-year-old patient who is admitted on a monitored unit with pneumosepsis. On shift report, the previous nurse tells you that the patient is in sinus bradycardia. On assessment, the patient's rhythm, you see the rhythm on the next slide. So I will give you guys a minute to look at that. We have a right bundle branch block. Yes, you got it. I'll let you guys look at those answers for a minute. So we have a right bundle branch block. So you were told your patient is in a sinus bradycardia, and you find this right bundle branch block. Do you have any concerns about this based on the report you received? Are you guys concerned? Yeah. And why are we concerned? New finding, exactly. Exactly. So this is a change in rhythm, and we always treat that as significant, especially in a septic patient. Um, do you think a junctional rhythm makes sense in this context? So sepsis can cause usually a myocardial depression and conduction disturbances and electrolyte shifts. So it does kind of make sense in the sepsis sense. Um, so what would you do next with this patient? Notify MD, yeah, of the new finding. 12 lead, great. 1 second, just plug it in my laptop. Okay. Um, Inform MD, yeah. We want to make sure we reassess our patient as well. IV access, yeah. Um, Check for cap refill, perfusion. Are they tolerating this rhythm? Has their condition changed since report? A little bit. We got our 12 leads, like you said. Checking our labs, electrolyte shifts. And then we want to think about the cause. So we know that she has sepsis, which can cause conduction issues. So could this junctional rhythm be a sign of progressive cardiac involvement or deterioration? Continue monitoring closely. Exactly. Do you anticipate any interventions for this patient? Yeah. What kind of interventions do you think? And this is a broad ask because ultimately we haven't assessed our patient yet to know what or if she has any symptoms. Checks X-ray. Yeah, it's a good one. If your patient is showing maybe signs of some hypotension, altered or slowing poor perfusion, what are some things we need to prepare potentially? Hmm. That could be one, especially if they're on the floor. Hmm. Losing my voice again. What medications or what interventions would you anticipate potentially happening if she's showing signs of poor perfusion? Fluid potentially, especially in sepsis. Epi or any inotropes or vasopressors if bradycardia. Epi. And then we go back to our atropine and potentially temporary pacing if she becomes unstable. But if she's stable, and somebody already mentioned this, we're going to continue monitoring, which is great. Repeat ECGs, and we're just going to kind of investigate underlying cause. And it could be sepsis progression, which is where maybe a chest x-ray would be great. So From this, just never assume the rhythm from report is still accurate. Also, we always want to reassess, especially in high risk patients, especially those who have sepsis. A junctional rhythm might seem okay, but in a patient who needs every ounce of cardiac output, especially in sepsis, it can be a red flag for a worsening conduction or cardiac compromise. Check if cultures are back. Absolutely. I find cultures often gets missed, especially if they take a few days. People forget about them. Hmm. Any questions about this? This was kind of a broad scenario. It really ultimately depends on how your assessment is. So just going back to never assume your report is accurate. Also look back at our previous ECGs and just ensure that that is accurate. A lot of times bundle branch blocks do actually get missed in rhythm interpretation. And maybe the last person just missed it. And we will go
There's
to
a question about the last rhythm in the
Mhm.
chat there.
Oh, let me go to it. Sorry, I just have pop-ups. The bunny ears. Sorry, I have to zoom in on this. Okay. Do you see the little strip? Actually, I have a laser pointer here. It is really blurry on my screen. Okay. Do you see these little, they look like bunny ears, just one ear's a little bit bigger than the other? The lopsided bunny ear. Boop, boop.
There's a question. Go ahead, Maya.
For the right bundle branch block, it only shows on V1, or does it also shows on different leads on the 12 lead?
We are not covering 12 leads today with our bundle branch blocks. This is just what you can see on a continuous cardiac monitor.
Okay.
So you can see your V lead on your continuous cardiac monitoring will show your bundle branch block. All you'll usually see on lead 2 is a wide QRS complex.
Okay.
When we get to 12 leads, you look at also look at V6, which we are going to talk about 3 sessions from now.
Okay.
But for your continuous cardiac monitoring, we look at the V lead.
Okay. Thank you.
You're welcome.
All right. So we'll go on to example 4. So this is a 62-year-old female presenting to the ED after experiencing sudden onset of lightheadedness and near syncope while grocery shopping. She reports episodes of fatigue over the last month, but has not sought medical attention. Her past medical history includes type 2 diabetes and coronary artery disease, and she had a stent placed in 2021. Her blood pressure is 100/60, heart rate is 51, rest rate is 18, SpO2 94% on room air, and temp is 36.5. She has mildly elevated troponin. Her K is 3.4 and her MEG is 1.8. This is lead 2 on your 12 lead. And I'll give you a minute to interpret that. We got a 2nd degree type 2. Yeah. I can see how at quick glance it does look like a third degree. So it is a second degree type 2. So, or Mobitz 2. So is this patient considered stable or unstable, do you think?
Just a few comments about some of the interpretations. So, a second degree AV block, we would not interpret as with an underlying rhythm. So we would not say like second sinus brady with a second degree AV type 2. We would only do that with a first degree AV block. For a second degree, we would call it just a second degree type 2 AV block. So I
And
hope
our
that
bundle branch blocks also have underlying rhythms, but
yes, in our I was talking in our AV blocks.
Yes.
The other thing with this, the reason that it's not a third degree AV block is because we can see that all our QRS complexes that are present do have a P wave associated and they have a constant PRI interval. So if you had a third degree AV block here, your P waves would be random and you wouldn't have a constant PR interval. So I hope that makes sense.
Just see our randomly dropped QRS complexes here.
Yeah, it's tricky. Sometimes the second degree type 2 can look like a third degree. So this is why in our previous sessions, I always say to measure 3 PR intervals, because if it's constant, it tells us that it is not a third degree, because in a third degree AV block, you would never have a consistently constant PR interval across your strip. So I hope that makes sense.
So do you think this patient is stable or unstable? I would agree. I would say unstable. She has symptomatic bradycardia. So her heart rate's 51 and she had a near syncope episode and she has some fatigue. Her blood pressure is low normal, but again, that is a later sign. So don't rely on your blood pressure alone. And then she does have a history of CAD and she has elevated troponin. So she is at increased risk for sure. What else do you want to know about this patient? Needs close monitoring for sure. What else do you want to know? 12 lead ECG for sure. We want to know if that ECG is showing ST changes as well. If she is rising troponin, especially.
This heart stent is still like intact, or is that a new block?
Exactly. Is this new or is this known for the patient?
Yeah, generally speaking, a second degree type 2 are quite dangerous and people wouldn't generally live in this type of block.
I've only ever met one patient that actually lives in this block.
Wow, I'm shocked that you
I
met
know.
someone.
Very, very young too. We want to look at medications again that affect conduction. Does this patient potentially have a pacemaker in place or a scheduled pacemaker coming in? Is this something already being followed up on? What interventions do you anticipate for this patient?
She needs to be admitted to the like monitor pad and the make sure IV access, and then 12-lead ECGs, and probably POCUS for the heart.
Yes, we love our POCUS. Overall, this is a high-risk rhythm, and it is known to progress into a complete heart block. So the major plan is escalation and preparation for this patient. So overall, we want to make sure we're stopping any medications that have some form of AV nodal blocking mechanism, electrolyte check, continuous cardiac monitoring, which you guys said, making sure that we have our MRP and potentially cardiology actually at this point. STAT, Center to the Heart Institute. I like that. We want to place our transcutaneous pacing pads on immediately. Be sure that we might need to mix up some infusions. So that's our dopamine epi again, if bradycardia worsens, and overall prepare for pacing potentially. The Mobitz 2 rhythm is usually never benign. Even in patients that seem stable at first, the risk of progression to the complete heart block is big, especially with people that have CAD or bradycardia and ischemic signs like elevated troponin. So this is a act a little faster scenario. And I would always anticipate deterioration quickly with these patients. Any questions? Yes, exactly. Don't waste time with these patients. Do we have oh, we do have another scenario. So we have a 75-year-old male who arrives to the ED with complaints of dizziness, difficulty breathing, and chest pain. The patient's partner states that the patient forgot to take his meds for 3 days, so he took 3 days worth of medication this morning. A 12-lead is done immediately, and the rhythm on the following slide is seen in lead 2. He has a history of hypertension and type 2 diabetes. He is on ditalazam and these other medications that are blurry on my screen. I think that says metformin at the end. Can you guys see it clearly, or is it just blurry for me?
I can see it clearly.
Okay, good. So interpret the rhythm and think about the interventions. It's only blurry when I take over the slides for some reason.
30 degree.
I have to step away, Amanda, so just let me know if there's any issues when I leave.
No, that's good.
Okay.
The 3rd-degree block.
Is it a 3rd-degree block? Yes, you got it. So if we can see here, I love this laser pointer, you can see that the P waves and the QRS complexes aren't communicating to each other. It's very random. So is this patient stable or unstable?
Unstable.
Unstable, automatically, yes. Yes. What makes them unstable, do you think?
It's a low blood pressure and the heart rate is 40.
Mm-hmm. So what interventions do we anticipate for this patient?
So firstly, put on the monitor, make sure all the IVs and oxygen is on, and pace transcutaneously first when they are trying to put the transvenous pacer, because I'm not sure whether transcutaneous would keep going, and then he needs a permanent pacemaker, looks like.
Perfect. Yeah, most likely it would be transcutaneous pacing and either shipping to somewhere that can do transvenous or right to the cath lab as well. So this is, again, this is not a patient you sit on. It's immediate pacing and go where this patient needs to go. And same with the pressors and inotropes, that's good. So whatever you can do to help their hemodynamics to keep that up. Good. And what do you think is likely the cause of this problem?
Because looks like he took the overdose of his medication, hypertension medications.
Yes, no, that's exactly it. Which we do see often enough in our elderly population or Alzheimer's dementia population. They forget that they took meds or they forget their meds altogether. It can go either way. But pacing is definitely number one with any third degree block. Throw those pacer pads on and get them where they need to go. So that being said, this patient's in a third degree block because of a medication overdose. What do you think is the long-term, or it can, yep, and it could be degenerative and aggravated by meds, yeah. So potentially a permanent pacemaker, potentially a temporary pacemaker. So a lot of times in these situations, they will put a transvenous in and wait to see if it resolves itself. And if it doesn't, they usually buy themselves a permanent pacemaker. Do you guys have any questions?
Oh, I'm good.
Okay. We finished early today. Yay. I think I just spoke way too fast, but if you guys do have any questions, I'll stay on for another 5 minutes. If you do, I will hang out. But otherwise, I hope you guys have a fantastic rest of your Wednesday. We are halfway through the week. Yay. And when to use the term high grade block? That is a great question. Truthfully, I have never used the term high grade block. I'm a general ICU and not cardiac ICU, but I will ask that question and get right back to you. Rebecca has the benefit of being married to a nurse at the Heart Institute, so we get all the good answers there, but I will dive more into that and email you if that's okay. Yeah. Oh, good. I'm glad. PRIs when they have pacemakers. If they're actively firing, I wouldn't do the PRI, but if they're on demand and your patient has an underlying rhythm, then you could do the PRI for those. But I think PRIs, while actively pacing, not super important. I mean, they can, but it's not going to indicate much. You're welcome. We aren't discussing those in particular in this course, but it could be something we take back to discuss in our next series. We're totally welcome to any and all feedback. So if you guys feel like we're missing something or maybe need to take out a few things, let us know. But I will take that back for sure. You're welcome. Have a good day, everybody. You're welcome.